Prior to joining the faculty at YSPH, Dr. Cameron was a member of the Global Health Cost Consortium, an initiative funded by the Bill and Melinda Gates Foundation to provide decision makers with improved resources to estimate the cost of HIV and tuberculosis programs and to improve the availability, quality, timing, and policy relevance of cost information. He holds an MA in International Development from American University and a PhD in Health Policy from the University of California, Berkeley School of Public Health. The title of his talk is Costing and Economic Evaluations in Implementation Science. He'll speak for about 45 minutes, and then we'll open the floor for questions and discussion. Here you go, Drew.
Thanks very much for that introduction, Debbie, and thank you to those who were kind enough to join the call today. I won't introduce myself any further than to say, as a member of the Center for Methods and Implementation and Prevention Science, this is a pretty sort of exciting opportunity to share some of the work that I've been involved with in the past. This talk, though, I'm going to focus largely on what might be for many of you a review of topics as they relate to economic evaluations and costing. So please do bear with me on that front. I'll try to get to some novel research findings towards the end of the talk, but this is sort of designed as anyone can participate. You don't have to have much of any background in economic evaluation or costing. So without much more, let me get into the topics here. Okay, so this talk is divided into three main sections. First, I'm going to discuss some key economics concepts that kind of lay the groundwork for the rest of the talk. I'll briefly cover some different types of economic evaluation and decision analyses, and how costing in particular is an important and often overlooked component of implementation science. Second, we'll get into the nitty-gritty of costs and costing. So what are they? Who uses them? How do you do it? And what are some of the key considerations that you have to make along the way when you are conducting a costing study? If you have a great deal of experience with costing already, some of you may find some of this to be familiar, so I'll apologize in advance, but I'm still eager for your feedback. And then finally, I'm going to briefly discuss the efforts of the Global Health Cost Consortium, which includes a website with a ton of great costing resources. So if you're more interested in costing and economic evaluation, I can direct you towards those at the end of the talk. And as part of that effort, I'll share some of the results of a somewhat recent publication, a systematic review of costing literature on HIV in sub-Saharan Africa, and another study that's in progress. So let me move ahead here. So there are four main takeaways. If you take nothing else from this talk, and I wouldn't blame you if you didn't, four things that I'd like you to walk away from this talk considering. Like, number one is perspective. I'll get into what perspective is, and time frame. These are two concepts that matter, I think, the absolute most in terms of economic evaluations and costing and how they're conducted, and the findings that you were able to generalize from these studies. I want to also leave you with the impression that although expenditures are real, they're real things you can quantify, costs really aren't. They're conceptual in nature, and they depend on a lot of different assumptions. So we'll get into the nitty-gritty of that. I'd also like to leave you with the idea that perfect is often the enemy of the good. I think that's a concept that's very familiar to anybody who's ever published a paper, for example. But on the flip side, little details in your decision-making and costing and data collection can matter a lot. So there's a balance that we try to strike when we do these types of studies. And then finally, reporting standards and quality are two areas that have a lot of room to improve in this field. I'll show you some examples of why. So what is economic evaluation? Economic evaluation is an often sort of misunderstood term. You've probably heard of monitoring and evaluation, which typically refers to monitoring processes for a program's implementation and ongoing operation. If you work in the social sciences, you've probably heard of impact evaluation, which typically refers to evaluating, say, health, social, or economic impacts of the program. These are all separate but related fields and methods. Economic evaluation is sort of an umbrella term. This includes a broad range of comparative methods to help to evaluate choices or trade-offs between costs and benefits. Another familiar term might be decision analysis. At the heart, though, of economic evaluation and decision analysis is a concept that we spoke about, or that I'll speak about a little further into the talk, and that is opportunity costs. So when we talk about economic evaluation, what we typically want to understand is what's the best value for money. And in the most basic sense, cost is what you pay and value is what you get. It's the benefit. So it won't always indicate a clear choice, but it will help to evaluate options quantitatively based on a defined set of decisions. These processes, they aim to capture opportunity costs of doing one thing over another. So for example, do we invest in home visits or do we make mass media platforms to disseminate behavior change communication for improved, say, infant and young child feeding practices? Or do we promote home gardens or vitamin A capsule supplementations to address micronutrient deficiencies? So lastly, I'll leave you with the thought that economic evaluations are comparative by nature. So not only do they compare costs and benefits, but a comprehensive evaluation will compare two or more different options. So let's look at a couple of different types of economic evaluations. So you may have come across these in the past. There's really a large family of economic evaluation methods. But it's important to note that all of these different types of analyses and tools at their core are measuring costs in dollars. So that column down the middle. And that's the main focus of the rest of this talk. But a key difference across these different types of evaluations is going to be whose costs it is that we're taking into account, as well as how we're measuring benefits. So all decision analyses are comparative, as I mentioned. We're going to compare one or more options in relation to another. So that other option could just be what the current standard of care is, or the status quo. It could be doing nothing, or it could be another active intervention. So one of the first things that we need to do in any such analysis is to understand what our comparator is. And the most basic type of economic evaluation is the one on the top there. We'll start with cost efficiency analysis, which is sort of a partial form of economic appraisal because it looks only at the costs of the program and it doesn't really provide any information on the, say, agriculture, nutrition, or health outcome of interest. This typically reports out on the cost per output achieved. So another example of this might be like a budget impact analysis, where you're looking at the cost per output, per patient served, or per vaccine administered. Now, the more common type of economic evaluation for evaluating health interventions is cost effectiveness analysis. In CEAs, they compare the cost and outcomes of two or more alternatives, or compare a new intervention or treatment with the status quo. CEAs relate the cost associated with the health outcome, such as cost per disease avoided, cost per death avoided, or additional expected life year, for example. And then there's some other types of analyses that we won't get into too much. Cost utility analysis, includes analyses with, say, disability or quality adjusted life years, or other standardized measures of preference. And then there's cost benefit analysis, which is a method in which both the costs and the benefits of the intervention are expressed in monetary terms. So in agriculture, for example, this might be the value of increased crop production. Well, in health, it would be the dollar value associated with the life years that were gained because of an intervention. There's several other types of decision analysis that I haven't included in this table, and they exist. So those include return on investment analysis, cost of illness analysis, and others. So as I've suggested, different sectors kind of use different of these approaches. So for example, global health and education disciplines have promoted the use of cost effectiveness analysis. Implementation science probably naturally falls under this category, or in the cost efficiency analysis category, with a little bit more emphasis on perhaps cost efficiency, depending on the scope of the evaluation taking place. And I'll get into that in a moment. Meanwhile, you might see agriculture or large-scale investment in infrastructure being evaluated using, say, a cost-benefit analysis. So zooming out to sort of the the level that we often interact with these types of evaluations, say an AIM 3 of your NIH proposal, depending, of course, on your desired evaluation type, you'll often want to arrive at really a simple division problem: the cost of a program or policy or intervention divided by the outcome in question. For cost effectiveness analyses, the outcome is some measure of effectiveness, particularly a health outcome. For budget impact analysis and cost efficiency, this might be an intermediate outcome, a per person vaccinated or a per patient served. But at its core, all economic evaluations boil down to this simple division problem. And I want to mention one more, slightly more complicated, but still simple division problem that you may have come across at some point, in the process of putting together a proposal. And that is one that builds very simply on the previous. And that's for cost effectiveness analyses that compares the cost effectiveness of the intervention in question to some particular alternative. So that's the ICER. And this stands for incremental cost effectiveness ratio. So usually the comparator here is a status quo or a standard of care, but it might be some new alternative you're considering too. Well, I don't know if I'm getting a question here or not, but I'll just continue with that. You can also use ICERs to compare between multiple different alternative interventions or configurations. You might end up with like a list of different interventions that you want to choose between using a process like a shopping spree scenario. I won't get into the details of that, but there's lots of different ways that you can use this tool. Let me move on. In this talk, though, I'm mostly concerned with the numerator. So how do we choose what counts and what doesn't count, what goes into the process of collecting data to inform these numbers? And how might we begin to distinguish between studies that do that well or do that poorly? So I want to get through a couple of key concepts here before we get started. And those are scarcity, opportunity costs, types of efficiency, and perspective. And I'll linger on perspective a bit longer than the others. Scarcity is one of the most important concepts in economics, and that's simply stated resources are limited. So whether we have relatively more resources, as within the US or say other OECD countries, or relatively fewer resources, as many low and middle income countries find, there's always trade-offs to be made in terms of investments and competing programs and activities. So it's a major consideration. The most powerful implication of the concept of scarcity is, of course, opportunity costs. So this refers to the simple truth that the use of resources for any one purpose precludes their use for another. And I have to say that opportunity cost is a really great concept for focusing the mind by counteracting our own personal tendencies towards inertia, which is to say the tendency to, say, unthinkingly continue this year what worked or what we did last year. Or for that matter, what didn't work particularly well last year. So thinking about opportunity costs stimulates some creativity about the best use of resources given the needs and alternatives that exist. And the problem of resource allocation then becomes, where can we get the greatest benefit for a given expenditure? And cost effectiveness analysis provides the sort of conceptual framework and methods to help make that determination. Efficiency, I'll just touch on briefly. There's two major types: allocative efficiency, which concerns the division of funds among different interventions, so HIV prevention versus treatment. This often involves complex choices, even if the health gains achievable in one area are greater than in another, because costs also differ. And then there's technical efficiency, which is about how we implement an intervention that we've decided upon. So for example, what's the best program designed to deliver ARV therapy. Both kinds of efficiency require good cost data in order to properly assess them. However, technical efficiency is only about costs, whereas allocative efficiency concerns health impacts as well. And then finally, perspective. And I'll spend a little more time here because I think this is a really key thing that we all need to be on the same level with. This is perhaps the most important concept. So different stakeholders have different experiences of cost. There's the societal perspective, which is what we consider the most inclusive and is often recommended for most policy analyses in low and middle income countries. In this case, all costs are considered regardless of who incurs them within a society. However, considering the perspective of specific stakeholders is particularly useful in helping to address those stakeholder concerns. So will a payer or an insurance provider lose money even though a society gains in net savings? Or should we align financial incentives? And how do we go about accomplishing that? So here's another sort of useful graphic for thinking about perspectives. And in the context of a cost effectiveness analysis, these are the areas in which you might consider your choice of inputs for costs and benefits for a program or intervention. So you'll see that in the rows of the table here. So many decision analyses are going to be taking a societal perspective to start, but let's drill down a little bit more where we're talking about the hospital perspective or a payer perspective. So this is sort of the narrowest definition. They'll have their own particular interests, and we can also think about this being done from the perspective of an employer, how we might think about the healthcare system as a whole. The next level out would be the payer perspective. And that captures the insurer, and that may be a government entity, so Medicare, Medicaid, and then zooming out even further, the societal perspective, and that captures this broader range of costs. Okay. I want to mention then the question arises: which of these perspectives should we choose? So in implementation science, it often depends on the priorities of those on the ground partners and the institutions that you're working with when you roll out one of these studies. So in low and middle income country settings, the guidance from traditional reference case examples, and I'll touch on those in a bit, tend to encourage including this broader set of perspectives, so the societal or the health system perspective. However, narrower perspectives are usually, these are more directed at the interests of key stakeholders, and that may be the number one priority in any one of these examples. So it really, in short, it really depends on the priorities of your partner agencies, and those who are rolling out whatever this intervention happens to be. There's a really great quote from this paper by Eisman and colleagues that just came out last year, and really it's a pragmatic answer. The perspective of the stakeholder and the decision makers who will be informed by the analysis should probably be prioritized. But you can also conduct analyses at multiple levels, as long as you're able to distinguish between those different levels when you write things up. So just keep in mind in this process that organizations that are adopting evidence-based policies, they really need to know what it's going to cost them in their setting, given their resources. But then there's a trade-off, and that is whose reality counts and who's being missed by these types of analyses. I don't know if those on the call have ever read anything by Robert Chambers, but I think a lot about one of his early books, Whose Reality Counts, when it comes to development interventions, when I think about this idea of perspective. Another consideration that's closely related to perspective is time frame. And so that is not just what costs and benefits should we collect, but when and where in the project life cycle itself is it appropriate to collect them. So one option, and we'll start with the first in that list there, is to focus solely on the short-term healthcare costs, which could include the costs of the intervention, costs of downstream healthcare. This approach is consistent with, I think, most budget impact analyses frameworks, particularly those mentioned in the chair's guidelines, which I'll provide some resources for later. And in the context of costing, this is usually on the order of about 6 months after a program's been implemented. So it's once that program has reached maturity, what does it cost to continue to implement? But that ignores another set of questions, which is, number two here, the intervention startup. And it might be extremely valuable to organizations and key stakeholders who are carrying out that evidence-based program to include these costs in order to capture some sense of what it would take for a system to start to integrate new practices, how long it might take for those systems to reach maturity. Another option, the third in that list, is to include additional research costs included in the design and development of implementing a new evidence-based practice. So that might be adapting that evidence-based practice to a local setting or an intervention. And it could also include some of the costs of say, monitoring and getting feedback from participants in order to adapt and to improve, I guess, the implementation of that process. And then finally, there's this question of future downstream costs and benefits, and that's particularly to patients and to program beneficiaries. So that's number 4 in the image that you see. And this is often included, as I mentioned before, in perspectives that are taken from the societal level. But all too often, they fall outside of the scope of interest for implementing partners and particularly for payers. And I'll just mention that this is one of the major downsides to many, if not most, economic evaluations that are conducted domestically. So this is a setting where the payer is often a private health insurer who has no monetary stake in the future health state of their clients, because in most cases, those customers might age out and move into a new health insurer, so Medicare, for example, when you turn 65. So I'll just mention that an analyst may choose to include any number of these different components of an intervention or these different parts of the time frame. But in any case, it's really essential to be able to distinguish between these different sets of costs and benefits and to be explicit about the scope, particularly for generalizability and understanding limitations. So let me go into costs and costing. I've kind of droned on for a long time here, but let's talk about what costs are. So there's many different sources of costs from donors and government providers, international and local NGOs, participant costs from households and individuals. There's also many different ways to describe and categorize costs. Say by the type of cost, are they real world costs or are they costs of a randomized control trial? Are they full or incremental? Or by cost category, so different types of inputs or organized by activities, or, as I mentioned, even by the timing of costs. If you remember my first major takeaway from the presentation, you should be starting to get an idea of why I say that, or my second takeaway rather, you start to get an idea here of the notion that expenditures exist, but that costs, they're a little bit fuzzier. They're frequently abstract and they depend on a lot of different factors. So 2 different kinds of costs to be able to distinguish between are economic and financial costs. So financial costs are those appearing potentially in the program expenditures documents. Meanwhile, economic costs are costs that are included or that include the value of all resources, regardless of who's paying. So the difference here is resources contributed by other entities. So for example, the local hospital, the clinical staff, volunteers, or subsidized costs, such as from an international agency paying for commodities. So note that when you see an economic costing exercise referred to in the literature, it typically subsumes financial costing when it's thought of in this Venn diagram. So we have a sense of what costs are and why they're important, but what exactly is costing? So we use this term costing as a shorthand to describe the estimation of the costs of producing health services, for example. So costing places a value on the total resources used to produce a good or service. It requires measurement of the amount of each resource, as well as information about the price of each of those resources. So costs can vary by contexts. So when one is costing, it's important to gather information about location, about time period, population, and a host of other factors. Some of the different types of resources that are used to produce health services might include human resources, drugs and supplies, medical or other non-medical equipment, or even patient costs. So what exactly do we use costing for? Well, costing is used in a range of research evaluations, programs, and in planning. Primarily, it's in the areas of financial planning and budgeting and priority setting that cost data is the most sort of visible, we'll say. So for example, cost data are used to evaluate the effectiveness of an intervention or to understand the efficiency of health delivery, but what are the cost drivers and how do these vary over time? So in ART, which is the example in the slide here, this figure is from a systematic review of the costing literature. This is one that I'll touch on later for antiretroviral treatment in low and middle income countries. It shows the different drivers of the average unit costs across 5 different settings. And this helps to show which cost inputs contribute most to the overall unit cost. So this figure, I think, does a really great job of showing the absolute difference in unit costs between settings. And in this case, it's by country, and it includes a lot of different settings within countries, and doing so over time. Oops, excuse me. So cost data are also used, as I mentioned, in efficiency analyses. So for example, this might be to examine how costs vary with different levels of service delivery. So understanding unit costs at different coverage levels is really important to predicting costs as programs tend to scale up or to grow. So scale is a really important component here. Now, these dynamics can be explored through the use of cost functions. So here, the figure shows this sort of interesting dynamic relationship between scale and unit cost for antiretroviral treatments across a large number of sites in sub-Saharan African countries. So you'll note that the relationship here isn't linear. It's a little noisy, but that makes it important to estimate cost functions and then to utilize different costs for different levels of coverage. So in this case, we can see that some suggestive evidence of economies of scale, which is to say that per patient ART services within facilities with larger numbers of annual patients tend to be slightly cheaper than facilities with fewer annual patients. So one thing to remember here is that although there's a wide range of different analyses that need cost data, they don't always use or need the same types of data. The purpose of the analysis in this case sort of dictates the type of cost that is required. And so it's really important that the purpose be identified at the outset. So, we have to consider budgeting, forecasting, efficiency analyses, priority setting, among others. Move forward. So before we go into costs further, I think it's also important to get some terminology right. In addition to the types of costs, there's also different measures of cost. So being clear about what each means, I think, is pretty central to understanding and interpreting cost information better as a field. So here are 4 different types of costing terms that you're probably familiar with, or you may have encountered some. But what do they mean? So the first is total cost, which is, as you'd imagine, the total cost of producing a service. And in healthcare, this is often presented as an annual cost. For example, the total annual cost of VMMC services at a clinic in a particular setting. The second term is average unit cost. And so this is the total cost per unit of output. And you'll notice that the units of output can be measured in different ways, even within the same service. So for example, there's a cost per person contacted or a cost per person treated. And I'll return to this a little later. The third term is marginal cost, which is a concept that's frequently used in economics and is really critical to efficiency analysis. And this is the additional cost of producing just one more unit of output. So for example, the cost of testing one more person or vaccinating one additional patient. And then the final term here is incremental cost, which also examines change. In this case, however, the focus is on the cost of adding a completely new level or type of service rather than adding one more unit of output to an existing service. So for example, the additional cost of adding counseling and linkage to care to current HIV testing. Most costing exercises, though, that you'll encounter tend to refer to either average or to unit costs. I want to give you just a quick example here of what a program costing table might look like. So this slide comes from a presentation by Dr. Jim Kahn, who is a mentor of mine at Cal. The example here is a small rural HIV clinic that was set up by a colleague of Dr. Kahn at UCSF, which I'll have to say is where he spent most of his career. And the two, in this case, conducted a costing analysis of this facility. So as you can see, the summary divides costs into 4 different categories. There's personnel at the top, antiretroviral medications, which are the dominant supply that were used by the program, lab tests, which is the main service that was provided by the program. And then there's this 4th sort of residual category of less expensive items. So administration, general supplies, vehicles, storage, utilities. You might find pencils in here. So the standard input categories here were adapted to conform to how clinicians think about major components of antiretroviral treatment. In this case, the columns show the units that were tested, the costs per unit, the resulting monthly cost for the entire activity, and the entire costs per patient for each line item. So in this case, for example, the full-time doctor costs $1,083 per month and $52 per patient year. So one interesting takeaway here is that the authors found that once the clinic had reached fully operational capacity, it was able to deliver ART at, it looks like, about $550 per patient per year. And they also found, which isn't shown here, that the cost could drop by about 1/3 with less expensive medications, as well as lower wage scales and modest increases in patient load. So just an interesting example to kind of put some of this into context. A couple of key costing principles here, and these are major takeaways, I think, from Jim as well. But in theory, you can do some really solid costing work if you adhere to really these 3 main principles. So the most important is that your goal is to quantify the resources required for program operation and the associated cost. And that means developing an inventory of resources and assigning appropriate costs. So this task is quite different than simply accepting a program's budget or their expenditure report, because that report might include costs that aren't required for routine program operations, like special evaluation needs of a funder. Also, even if the costs are accurate, you've likely learned nothing about how the program operates. So specifically, what types of inputs might be available. The number 2 point, that Jim makes often, is that you should be systematic and thoughtfully thorough. And by systematic, we mean that the search for resources should include all of the usual input categories like personnel and equipment, the range of activities such as marketing and service delivery. But by being thoughtfully thorough, what Jim refers to is that all of the significant resources should be included, quantified, and costed. But minor costs, truly minor things like routine stationery supplies or routine services, pencils and erasers, they can often be safely ignored if the data collection in order to obtain those is too onerous. So of course, that's like a judgment call. And one suggestion, that Jim makes is to use a table and kind of order resources from the most to the least expensive so that you can empirically identify, say, a cutoff for each of the resources that are considered maybe too minor or that may not play into the overall costs as much as you might be concerned about. So, this is really getting into fine detail. Do you really need to cost that last pencil? And then finally, as we mentioned before, adopt the appropriate perspective. So I've talked about this at some length, but it's worth reiterating. I'll go over, I think I might skip past some of the typical costing categories, except to say, these are some examples. They may often go as far as to include patient costs. They may also vary by program and over time. The time frame, which I mentioned earlier, typically when we think about a costing exercise, it's about 12 months or its multiples thereof. And the reason for this, for annual costing, is that it has the hallmark of conforming to our pervasive and programmatic record keeping, which is really nice. But it can also help to deal with distortions, seasonal effects and shocks. It smooths a lot of random variation. So that could be for like the calendar year or the fiscal year typically. Portraying costs by month, if it's easier, might indicate how costs vary over the course of a year. So that's another consideration. And, again, if we're talking about fully operational programs, we want to make sure that the program is actually matured. But again, that might ignore some of the startup costs or other costs that I discussed earlier. One other little piece of terminology that I want to cover is gross versus macro and top-down versus bottom-up. So you might have come across this a number of times, in proposals or mentioned sort of casually in the literature. Microcosting focuses on really granular accounting of inputs, as opposed to macro costing, which is, gross costing. I always get them confused. A gross costing approach that might simply estimate all of the relevant costs, typically from program expenditure data, and then dividing the associated outputs, so like patient episodes. In contrast, we've got the bottom up or top down, which refers to the way in which each resource is allocated to the total unit cost being estimated. So top down costing divides overall program costs or expenditures, often including those which are above the service delivery level by the number of outputs in order to calculate the unit cost. Whereas bottom-up costing measures input quantities at the client or activity level. So gross costing, for example, is commonly done top-down, for example. And then micro-costing kind of has a bottom-up approach. I'll skip over, well, let's see, Debbie, we're at 43 after. I want to mention pricing and valuation very briefly before moving into some of our other findings, simply because I think there's one example in the popular press right now that's really worth consideration, particularly if you're operating in low and middle income countries. And I'll just point to the fourth bullet here, inflation. So inflation comes up a lot. In the popular press because we're experiencing rapid inflation in the US right now. But I want to linger on it for a second, simply to say, the operation that you use in order to account for inflation in different country settings matters a great deal. So the example here is, let's say that you've collected a piece of critical cost data from a program in Tanzania. The unit cost of the service in the year 2000 is, say, $100. So, the typical strategy is to use a US price inflation tool, so typically the GDP price deflator, and convert that into US dollars in order to inflate over time. There's some recommendations in the literature that this should be done in a different order of operations, and that would be to actually inflate in local inflation before converting into US dollars. And the implications for that, so in the next slide here, are pretty substantial. So, in Tanzania over that same period, inflation was quite rampant. And so it really changes the overall dollar amount that you're looking at in the last period of the cycle there. And it's even more volatile when you include other countries in sub-Saharan Africa over the same period. So your choice of inflating first before exchanging into US dollars, or exchanging into US dollars and then using a US inflation process can have some really substantial implications. I just wanted to highlight that. I'm going to push through some of these final notes here because I'd like to get to some of our findings. I do want to leave you with 3 key resources at the end, and those are the Consolidated Health Economics Evaluation Reporting Standards, or CHEER standards. There's a new update to those standards that was published in 2022. And then for those working in low and middle income country settings, Vassal and colleagues reference case for estimating the costs of global health services and interventions, and the Bill and Melinda Gates Foundation 2014 guidelines that come through their reference case. And I'm happy to share those resources after the talk. But let me get into costing in practice here because I am running quite low on time. So the Global Health Cost Consortium, as Debbie mentioned at the top of the hour, was funded by the Bill and Melinda Gates Foundation. I was involved with this project for about 4 years, and 2 of the outputs from the project were our unit cost study repository, which I'd invite you to visit. And that's really a one-stop shop for all of the published cost data from HIV and TB interventions that were conducted in low and middle income countries settings really over the last 20 years or so. So we went through a pretty long, painstaking process of extracting primary cost data, that is costs that were not modeled, from the published literature, standardizing them across several hundred different variables, and then making them sort of available to the public at large in a pretty easy to use drop-down type of database. So if you're ever doing any program planning for HIV or TB interventions, I'd invite you to visit that site and see if you can get any utility from some of the efforts that we put forward. Another big output was the reference case that I mentioned before, guidelines for estimating costs for global health interventions. And again, happy to share those after the talk. Another major output here was we were able to produce several different publications. So I'll present a little bit of the findings from that. So over several years, our team conducted the systematic search and screening of peer-reviewed and gray literature. We had a few different goals here. We wanted to describe the quantity and characteristics of published costing data, to identify production patterns over time, so geographic location, publication venues like journals, and authorship, and to look into key methods and reporting standards to try to identify gaps in the costing literature. So I'll go over some of those findings. So figure 1 here shows the results of that search and screening process. So we covered articles that were published starting in January 2006 through October 2017. So it's a couple years old now. We use 6 databases, so PubMed, Embase, Web of Science, Cochrane, and a number of others. I'm going to give you high-level content here. So searching also included gray literature, which you see on the right-hand side. And we identified over 23,000 possible titles, including nearly 500 known costing studies that we had started with. So from these, we were able to screen down to 217 relevant titles that got included in that unit cost study repository, the database that I mentioned before. And of those, we published 1 study among 159 published studies that had taken place in sub-Saharan Africa. So I'm going to discuss really briefly 2 different studies that came out of the effort. And the first was that 2019 study that I just described. And the second is a study that's in progress where we're reviewing findings from the detailed extraction of the 243 studies that we started with in the lines above. So I might jump a little bit between findings in these 2 different venues. So the first study focused on that evidence from sub-Saharan Africa. This gave us a really nice picture of where costing data is and isn't collected on the continent. The studies we identified took place in 25 countries, so mostly East Africa and Southern Africa. And although this sort of geographic variation is broad, we found that the quality of evidence within many of these countries is, or the quantity rather of evidence within these countries is quite sparse. So West Africa doesn't have a great deal of primary cost data in the published literature. A lot of it, is often modeled. In terms of who is publishing studies that report on HIV intervention costs, there's a few notable peer-reviewed journals. So PLOS One, J-AIDS, and AIDS are kind of our leaders. But I think the big takeaway here is that there's an awful lot of potential destinations for published primary cost data, and more so than I think we realized when we set out in this exercise. So you can see the large list of different published studies on the left, or sorry, journal destinations for published studies on the left. And the table in the right, these are gray literature resources. So these are the sources of gray lit. A few key players here, USAID, PEPFAR, the Futures Group, Health Policy Project, and Pangea. And Bill and Melinda Gates had their fingers in a lot of these different published studies, but these are the destinations. One thing that I do want to mention here is that although we're examining this subset of primary cost data that was collected from studies in sub-Saharan Africa, there's a little bit of a disconnect here in terms of where we find that primary cost evidence is being published and where leaders in the field, at least 9 years ago when the first CHEERS guidelines paper was published, that there's, in that paper, there was an explicit effort to identify leading journals as landing places for health economic evaluations. But what we find is that of the 10 that they identified in that CHEERS statement paper, only 3 were we able to find in our larger systematic search of the HIV literature. And this is, beyond sub-Saharan Africa. This is that paper 2 that I mentioned. So this isn't necessarily an indictment of the list that was generated by the CHEERS authors, but it does highlight, I think, a large and varied number of journal sources where these data are published. And it emphasizes the need to be sure that these standards, like the ones laid out by the CHEERS document, are being upheld across different publications. So, a large growth in publications over time, a difference in the time to publication. So peer-reviewed studies tended to take 2.8 years on average to get published. Whereas those in the gray literature, 1.4 years. So this is much more quickly disseminated into the zeitgeist. The ability for folks to actually start to use these data for their own program planning purposes. Scale, I'll mention. This is probably our most substantial finding, and you don't need to spend a lot of time poring over this table, but this was actually quite damning. If you don't take anything else away from this presentation, I think, I hope that this resonates, that reporting of scale is, it's a really critical, important component of any costing exercise. But what we found is that in the 6 of the intervention types of all the studies for which we were able to collect data, the average number of unit costs in those published studies, scale was reported below 50% of the time, and in some areas as low as 35 or 26% of the time. So in total, I think the average, that we found was something like 44% of unit costs have explicit measurement of scale associated with those reports. So that's a problem. That's something that needs to improve in the field. And then I'll also mention perspectives. So despite, I think, recommendations and urging from, say, the Gates Foundation's reference case, which I cited earlier, which emphasizes that authors should focus on societal perspectives as much as possible, we actually find here, in terms of what folks in these articles report as their given perspective, and when we clean it up and we figure out among those who didn't report what their perspective was, by the way, 15.6% of studies that we uncovered don't report a perspective, which is, again, a problem for reporting standards. Only 7, or about 2.9% of the studies that we identified take a societal perspective. So, most of this is done at the level of the provider. So, gives you a little bit of context, I think, for where there's room for growth. So in conclusion on these points, I want to say that there's, a few final recommendations. We recommend that future costing and cost effectiveness studies closely follow the Gates and the GHCC reference case. And that there needs to be more detailed reporting on a number of different items that I wasn't able to touch on in this talk, but most of all, I think scale is something that's really missing in the literature. So I won't touch on this too much, other than to say there's some future research that we're working on to determine the quality of some of these cost data. So be on the lookout for publication on that in the future. And now that I've ran through all of our Q&A time, I do want to thank you for attending, and I'm happy to take any questions. Yeah, Reza.
Thank you for the great talk. So I had a question comment about the societal perspective. I think in certain scenarios or situation, this could be a little bit tricky. For example, if you take vaccine for some infectious disease in low-income countries, usually the price is heavily negotiated between the pharmaceutical companies and donors and NGOs. And if you take the societal perspective when you are doing the cost effectiveness analysis, including the productivity loss, the income loss, the vaccine becomes extremely cost effective or even cost saving. Mm-hmm. So even if they price the vaccine to $50, $100, still it becomes cost saving, which is it becomes an excuse in hands of the pharmaceutical companies to jump up the price of vaccine because it's such a cost-effective strategy. So I don't know if you have thought about it. I have purposefully avoided taking societal perspective in those contexts because I just don't want to put these numbers out. But I don't know if you have comments, thoughts.
Yeah, no, I mean, that's a great point. I often don't think far enough along the causal chain to consider sort of the potential negative externalities of price gouging, in those contexts. I guess I'll say, at least in the context of what we found in our search of the literature, and there were a few of those different intervention types that dealt with pharmaceuticals. And the costs of those being, not insignificant drivers of overall program and unit costs, for HIV care, that most of the studies that we identified, really do focus in, don't tend to focus in on the societal level. So it's not, perhaps that type of crisis hasn't borne out necessarily as a result of some of this in the literature, but it's definitely not something that's discussed as often as I think it should be. So you raise an excellent point, and and one that I hope gets added to further discussions in published literature and in forums like this. So I don't have a good anecdotal example to share, but I really I like the point. Yeah, Jeremy.
Yeah, Drew, thanks so much. This was really informative. I actually wonder, maybe building on that on the previous question, if you could go back to the slide with the table from that rural Uganda study, because my question was about sort of, was this a financial or economic perspective that was being presented? And I was honing in on the ART, because presumably, through PEPFAR, from the program's perspective, ART should have been without cost and also without cost to the patient. Mm-hmm. So which made me think, well, maybe this is an economic perspective, but then there are all those other pieces of getting the medicine to the patient, the whole supply chain and whatnot. And so I'm just wondering if you have a sense of like, was this trying to describe programmatic or economic perspectives, and how, and if this is economic, should we truly be thinking about like that whole process? Like where in the supply chain do you start counting?
Yeah, I wasn't involved in this particular study, and so I'm happy to field that question to Jim, because he uses this example in his talks. My sense is that this is programmatic. It does seem fairly narrow in scope, but you raise a really good point, I think, that Reza raised as well, which is, it depends on who's providing that, where the supply chain is coming from. And that obviously has downstream implications for, how you deal with the costing procedures in, these different income country settings, how you'd inflate and how you'd adjust. And so supply chains don't often make it into the discussion in these write-ups, but they need to, right? Because that's a really critical component. I don't know if that answers your underlying question.
Yeah, I think it gets to it, for sure.
Okay. Yeah, and like I said, I'm happy to reach out and find out a little bit more about this particular example. But it's a good question.
Great, thanks.
Yeah. I do realize we're at the top of the hour. I'm not able to see the chat very well, so if there's anyone that would like to raise anything from there that I'm missing, I'm happy to field those.
Drew, I would just say that before David Paltiel ran away, he said that for what it's worth, his concern is the mirror opposite of Reza's. When we abandon the societal perspective, interventions that have broad public benefit can be greatly undervalued because they're not germane to the narrow decision maker, and real economic resource use, such as volunteer time and effort, can be ignored because it looks free to the narrow stakeholder.
Mm-hmm.
So and I would also say that my question, and this is one not as an economist that I've wondered about for a couple of years, is that from an equity perspective, I actually wonder about the household level perspective as opposed to the individual level perspective. Mm-hmm. That we leave, I've never seen one of these presentations that looks at the household level, and yet it's at the household level that cushioning of resources and equity balances often happen, not at the individual level. And so I'm just curious, from your experience, have you ever seen work done at the household cost level? Yeah. And what do you think about those equity as an equity perspective?
Yeah, I mean, I think there's some downstream costs there that, in theory would get some subsumed into a societal perspective. But I struggle to think of specific examples that kind of cast the umbrella wide enough, or cast the net wide enough to include other individuals within the household. So I think that's a really great point. And it speaks to the demand side part of this question in a way that's really, potentially quite meaningful. And I would tend to think that, as you suspect, we'd be moving towards even greater downstream benefits at the household level. So I am working on one study right now in Uganda, actually, with Jeremy, who I think might have jumped off, where we are investigating patient costs as a component of that intervention. And we do tend to ask, in the scope of collecting patient cost data, about opportunity costs that are germane to the rest of the household. So we'll often ask questions about household expenditures and household income generating activities, as well as durable assets of the household, and ways that households can sort of deal with shocks over time. Because those are all really important questions, I think, that play into, what the experience of a patient is like, particularly in a lower middle income country setting, where one of these interventions might have a really meaningful downstream impact on, on the rest of the household. So it's something that I spend a lot of time thinking about, because I kind of started in that world, I think, before coming into the economic evaluation world. And it's one that I think doesn't currently receive a great deal of attention, but ought to. But again, to Reza's warning, I think you have to be careful about, how much generalizability you pull and try to tout from different studies like this, because right, they have different implications for different parties. And so, I'd like to see a standard, not where one perspective is chosen over another ad nauseum, but where they're both incorporated and where there's a societal and a financial or a programmatic perspective presented within the same paper. And readers of those pieces of evidence can then decide for themselves, like, which is the perspective that's the most meaningful. What are the trade-offs, along the way? Because the value add of that is substantial to add in a societal perspective piece to a published economic evaluation.
So I think we do need to wrap up, but thank you, Drew. I think that's very helpful, and we will have the video available for people. And really appreciate your time in preparing all of this material and sharing it with you, with all of us.
Appreciate the invitation, and thanks to those who attended today. It's nice to see some faces.
Okay.